Today we'll discuss about cardiomyopathy. This cardiomyopathy can be asked in your detail, or each of the cardiomyopathy can be asked as a separate 7-mark question. Okay. Starting off with the types. First and foremost, most common cardiomyopathy is dilated cardiomyopathy. Second is hypertrophic obstructive cardiomyopathy. Third one is restrictive cardiomyopathy. And fourth is left ventricular non-compaction. And fifth one is arrhythmogenic right ventricular cardiomyopathy. So this is arrhythmogenic right ventricular cardiomyopathy. In this video, we'll talk in detail about dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy and restrictive cardiomyopathy in detail. Okay. So going off with this, each of the cardiomyopathies, we'll be discussing about its causes. Next, its pathogenesis, clinical features, its ECG findings, echo findings, X-ray findings, and management. So in each of these three, we'll discuss about all these topics. Okay. First is dilated cardiomyopathy. Dilated cardiomyopathy is the most common cardiomyopathy. So most common cause of dilated cardiomyopathy is idiopathic. Okay. So among familial cases, autosomal dominant is the most common cause. Okay. So I'll go it in detail. First is causes. Among causes, first is muscular dystrophies. In muscular dystrophies, we have Duchenne muscular dystrophy, Becker muscular dystrophy, limb-girdle muscle dystrophy. Okay. This can be one of the cause. Second, myotonic dystrophy. So this both will come under neuromuscular disorders. Second, this is first. Secondly, we have inborn error of metabolism. Among inborn error of metabolism, the dilated cardiomyopathy can occur in fatty acid oxidation defect. Second, in organic acidemias. Among organic acidemias, it can occur in propionic acidemia. Most common is propionic acidemia, carnitine abnormalities, and mitochondrial abnormalities. So these are the causes, IEM causes of dilated cardiomyopathy. Third is we'll discuss about the genetic syndromes that can present with dilated cardiomyopathy. So the genetic syndrome that can present with this dilated cardiomyopathy is Alström. This can be asked in your NEET PG question. So the following syndromes which can have the dilated cardiomyopathy. Okay. Next, we have genetic mutations. So among genetic mutation, the mutation in the desmosomal gene. So mutation in desmosomal gene can lead to this dilated cardiomyopathy. So this is the most common form, as I told earlier, but the most common cause among all these is, so the most common cause is idiopathic. Among familial cause, it is autosomal dominant disorder. Okay, is the most common. Next, going off with its pathogenesis. In pathogenesis, the main defect in dilated cardiomyopathy is systolic dysfunction. So systolic dysfunction is the primary defect. Okay. Next, as the name suggests, there will be dilation of both right ventricle and left ventricle. In echo, you can see the ventricle and the atrium size can be proportionately equal. Okay, so there is some primary defect here is systolic dysfunction. So the cardiac muscle or the systole, that there won't be a good ejection, stroke volume, that the ejection fraction will be less in this patient because of the stroke volume will be less because there is a systolic dysfunction. Okay, since the blood will stay in the chamber because of the systolic dysfunction, dilated cardiomyopathy, this blood will stay in this ventricles and also in the atrium. This can lead to a formation of thrombus. So intracavitary thrombus formation is common. So among the cardiomyopathies, the intracavitary thrombus formation is common in dilated cardiomyopathy. This can also be one of your PG question. Okay, is common here. Next, going off with its pathology. In biopsy, you can see myocyte hypertrophy and fibrosis. So the clinical features, the patient that can present with history of fatigue, weakness, dyspnea and orthopnea, all the features of cardiac failure. The child or the person can present with fatigue, weakness, dyspnea, orthopnea. Okay. On examination, there will be increased heart rate, that is tachycardia, narrow pulse pressure. Next, you will be having precordial cardiac impulse will be increased. Precordial cardiac impulse. And this apical impulse will be shifted out and down, that everybody will know. So precordial cardiac impulse is increased here. When the child will present you with the cardiac failure symptoms, of course you will be having gallop rhythm. You can find murmur of MR or TR can be present. There will be pulmonary congestion. Because of this pulmonary congestion, you can hear basal crepitations. Okay. So these are the clinical features, and on examination you can find this in dilated cardiomyopathy. The ECG changes that you can see are non-specific T wave changes and the child can present with arrhythmias. It can be ventricular or atrial arrhythmias. Okay, and you can also have this hypertrophic changes. Left ventricular hypertrophic changes can also be present here. In chest X-ray, you'll be having cardiomegaly with pulmonary vascular congestion or pulmonary vascular prominence. And okay, this can be your X-ray finding. Next, in echo. Echo is the diagnostic one. So echo features of dilated cardiomyopathy, you can have left ventricular enlargement as the name suggests, and there can be decreased ventricular contractibility. Since primary pathogenesis is systolic dysfunction, the ventricular contractibility is decreased, due to which your ejection fraction will be low and stroke volume will also be low. Since the stroke volume is low, to maintain the cardiac output, you are having this increased heart rate. You know that cardiac output is equal to heart rate into stroke volume. This is stroke volume, this is heart rate. Since in this child with a dilated cardiomyopathy, the stroke volume is less. To compensate for that, this heart rate will be increased to match the cardiac output. So you are having a tachycardia in this patient. There's in echo finding, you have a decreased ventricular contractibility. So this is about the echo finding of this dilated cardiomyopathy. I've I've told only the main points that you can write it in your exam. Okay, I've not gone into very detailed one. Next, going on to its management. So, to reverse the cardiac remodeling. So, it is to reverse the cardiac remodeling, you have to use drugs. So, what are the drugs that reverses the cardiac remodeling? One is ACE inhibitors, or you can use ARBs. Okay. Next, other drugs are beta adrenergic blockers. So beta adrenergic blockers are, you can use carvedilol or metoprolol. Okay. Since to reduce pulmonary congestion or symptoms of pulmonary or systemic venous congestion, furosemide, that is Lasix, is being used. Okay. Since intracavitary thrombus formation is common in patients with dilated cardiomyopathy, anticoagulants is being used for prophylaxis. Okay. If the patient gets arrhythmia, use antiarrhythmic agents. Next is pacemakers. Other management options, pacemakers, that is dual chamber and biventricular pacing therapy is being used. Dual chamber and biventricular pacing therapy. Next, ultimate treatment. So ultimate treatment option is, or ultimate therapy is, cardiac transplantation. Okay. So these are the points you have to remember when they ask about dilated cardiomyopathy. If you remember these points while you are writing your theory exam, it is more than enough. Okay. So this is about dilated cardiomyopathy. I'll share the written PDF of this in our Telegram group. Next is about hypertrophic cardiomyopathy. Okay. So going off with its causes. This is the potentially, so among the cardiomyopathy, the potentially life-threatening cardiomyopathy is this hypertrophic obstructive cardiomyopathy. So going off with this causes, starting off with the inborn error of metabolism. The causes of, among inborn error of metabolism, we have mitochondrial disorders. In mitochondrial disorders, Friedreich ataxia can present with hypertrophic obstructive cardiomyopathy and storage disorders. In storage disorders, you can have this Pompe's disease and all. Pompe's disease, what we have, both dilated cardiomyopathy can also occur and hypertrophic cardiomyopathy also can occur in Pompe's. Next, second, genetic mutation. So among dilated cardiomyopathy, there will be a genetic mutation in desmocyte, right? I told that, right? Desmosomal gene mutation will be present. So in hypertrophic, there will be a gene mutation that is encoding cardiac beta myosin heavy chain. Okay, and myosin binding protein. So when there is a gene mutation in cardiac beta myosin heavy chain and myosin binding protein C, this can result in HOCM. Okay, HOCM. Next, third, among the syndromes, genetic syndromes, Noonan syndrome and Beckwith-Wiedemann syndrome can present, this both child can present with HOCM. How come? And the child born to mother of, whether with gestational diabetes mellitus, it is infant of diabetic mother, can most common this heart disease that can present as asymmetric septal hypertrophy. So the child can also have this asymmetric septal hypertrophy, or the child can have this hypertrophic obstructive cardiomyopathy also. Okay, next, going off with its pathogenesis and its morphology. So in morphology, as the name suggests, the left ventricle wall will be thickened. That is both left and right. So the ventricular wall will be thickened. So you have to write the ventricular wall thickening will be present in the absence of structural heart disease or hypertension, because in adults hypertension can present with ventricular wall thickening. So ventricular wall thickening will be present in the absence of structural heart disease or hypertension. 1 plus next, the child the patient can have asymmetric septal hypertrophy. Okay, these are the two main findings in morphology as the name suggests. So ventricular wall thickening and asymmetric septal hypertrophy, due to which there will be internal chamber diameter will be reduced. So the internal chamber diameter is reduced. Fine. Since there is a septal hypertrophy, there will be a subaortic obstruction. So I'll draw it here. So this both wall are thick and the septum is also thickened. There will be asymmetrical septal hypertrophy. Here you have this aorta. This aorta will be coming out of this left ventricle. So because of this septal hypertrophy, there will be a subaortic obstruction, plus there will be this anterior mitral valve motion. Anterior motion of this mitral valve can also lead on to the this subaortic obstruction. So there will be a subaortic obstruction. This subaortic obstruction is mainly caused because of systolic anterior motion of mitral valve. Okay. So one is subaortic obstruction. Next, secondly, because of the thickened ventricular valves, the diastolic ventricular filling is impaired. So diastolic ventricular filling. So the diastolic ventricular filling is impaired by this abnormal stiffness of this ventricle. So this will lead on to left atrial hypertrophy. So this will lead on to left atrial hypertrophy, which will cause pulmonary venous congestion and congestive symptoms. So this will lead on to pulmonary venous congestion and the congestive symptoms. Okay, so here the main abnormality is diastolic dysfunction will be present. Now what about you'll be asking, what about the systolic function here? The systolic function in this patient can be normal or it can be increased, because the 80% of the ejected blood, 80% of the ejected blood will come in first flow itself. Okay, so this to compensate, as I told earlier, to compensate for this cardiac output, the stroke volume will be increased. So for the stroke volume to increase, the systolic function has to increase. So the patient can have either normal or increased systolic function. Here there will be mean diastolic dysfunction or diastolic impairment, filling impairment will be present in this patient. Okay, next, going on to the clinical features. 50% of the cases can present with murmur, plus the symptoms are the child can have palpitation, chest pain, easy fatigability, next syncope and dyspnea. Okay, these are the main symptoms. On physical examination, there will be overactive precordial impulse with heave. This will be asked in your Viva session, right? So there will be overactive precordial impulse with heave, lift or heave. Okay, next, since there is an subaortic obstruction, there will be a ejection systolic murmur in the aortic region without click. Okay. Sometimes there can be this mid diastolic murmur can be present here because of this MS. Okay, I mean not definite MS, but it can have that. In ECG findings, you will be having left ventricular hypertrophy, findings of left ventricular hypertrophy, ST segment and T wave abnormalities, and WPW syndrome can also be present in your ECG. WPW syndrome can present in when there is a WPW syndrome in your ECG finding, you have to think of two syndromes. So that is a homework for you. So please identify what are the two syndromes you have to think of. Okay. Next, the chest X-ray finding. In chest X-ray, there will be mild cardiomegaly or no cardiomegaly with left ventricular prominence. In echo, this echo is used for identifying, localizing and quantifying the degree of this myocardial hypertrophy. Okay. Next, in management, you have to first and foremost management is rest. That is restriction of from strenuous physical activity will be the first. Second is beta adrenergic blockers. So beta adrenergic blockers that you can use here is propranolol, atenolol or metoprolol. Okay. Next, third group of drugs is calcium channel blockers like verapamil. So this beta adrenergic blockers and this calcium channel blockers are useful in diminishing the left ventricular outflow obstruction. So they are useful to reduce the left ventricular outflow obstruction, one. Secondly, modifying the left ventricular hypertrophy. And for third, improving the ventricular filling. Say okay ma. So mainly use beta adrenergic blocker and calcium channel blocker. Next, third management is implantable cardioverter defibrillator. Okay. This implantable cardioverter defibrillator is mainly used for patients with documented previously aborted sudden cardiac death, strong family history of sudden death or unexplained syncope. You use this implantable cardioverter defibrillator. Next, fourth, and you have to screen the first degree relatives. Okay, so first degree relatives should be screened every 3 to 5 years for patients less than 12 years of age, then yearly throughout their life. Okay, so this is the short gist about hypertrophic obstructive cardiomyopathy. In next video I will cover, since it is a too lengthy one, next video I will cover about restrictive cardiomyopathy. That will be a very short topic. Okay, thank you. Please like, share and subscribe our YouTube channel. Let's all learn our pediatric